I'm going to introduce our first speaker today. He is Dr. Clarence Lei. He's a consultant urologist at Norma Medical Specialist Center, Kuching. And at the same time, he's also the adjunct professor at University Malaysia Sarawak. Without further ado, I would like to welcome Dr. Clarence. He's going to talk to us about overview of advanced prostate cancer in Malaysia and evolving landscape. Welcome, Dr. Clarence.
Okay, Dr. Heng, thank you for your kind words. So I will share screen now. Okay, share screen. Right, Dr. Heng, can you see my screen now?
Yes, I can see, clear.
All right, good afternoon, ladies and gentlemen. I'm very much honored to give this lecture, but unfortunately, I'm not going to give you any answers to this drug. Tonight, I'm not going to talk about drug. I'm going to talk about in fact, not about Malaysia, mostly about East Malaysia. So I'm going to give you some background information about prostate cancer basically in Sarawak, only in Sarawak. Okay, so I'm going to talk about, actually from Kuching, my personal cases, the current patient profile and the treatment. And I will emphasize that prostate cancer is a common and slow-growing cancer. And from there, we take any perspective as to whether there are any unmet needs, how we are diagnosing it, how we compare with the other parts of the world. And finally, we'll talk a little bit about precision medicine and how practical it is in Sabah, Sarawak. Okay, prostate cancer is very, very common. I'm 65 years now. So if I die today and they do a postmortem on me, the chance of me having prostate cancer is 70%. So prostate cancer in postmortem studies is extremely common, and it's often said that every man will have this cancer if you live long enough. Okay, it's very common cancer indeed. And we also know that genetics has an important part to play in many diseases, including prostate cancer. So they say that if you have a young relative under 50 with a few relatives with prostate cancer or breast cancer, your risk is much higher. But we still don't do PSA as a screening for prostate cancer. We still don't do it. We can discuss later on if we have enough time. But basically, the absolute risk is not that high for young people. So actually, we don't do PSA screening for prostate cancer. That's one of the reasons. But because it's so common, if you look at the Malaysian data, it is still the third commonest cancer. This is the data up to 2016, and this is the latest data from last year. Prostate cancer, number 3. Colorectal, lung, very close fight. They are very close to each other. So this is the incidence of prostate cancer. Okay, now the next few slides are about my so-called personal series. Personal means I have the records in my e-folder, in my e-folder, but not all of them. In fact, most of them are not completely managed by me. They are managed by a team of us. Sarawak urologists, there are 7 of us. And of course, these patients come from all over Sarawak. So they are managed with the local surgeon, the local general practitioner. And I see from the participants, many of them are actually my collaborators. Thank you for helping me to look after these patients. These are up to 27th of July. I have 88 cases. In fact, I have three more which I cannot find the records. Cannot find the records. I'll find them next time. The commonest are those above 60. The youngest patient is 43 years old. And he looked for me because the grandfather also had prostate cancer. And his PSA was 93. He has a high grade 4+5 Gleason score. And all his 12 calls are positive. So actually I think, will be one of the candidates which will be using what we're going to talk about tonight. During the COVID pandemic, of the 88 cases, many of them, actually, I have not seen them for at least a year. But now with WhatsApp, with email, they will keep me informed of the progress, and I send them to the local doctor for their treatment and for the physical examination. Because obviously with telemedicine, we cannot really examine them. All these patients are local patients. That means they are Sarawak patients, except for one, who is from Jakarta. So I liaised with the urologist in Jakarta to look after him. Only one Caucasian. He is an expert in the oil and gas industry. So this is the demographic profile of the patients in my e-folder. What about other characteristics, which I had a quick look at. One of them is the PSA. Almost all of them have a very high PSA. Normal PSA, you know, is less than 4. So many of them are in their hundreds or even thousands. 2 of them have a PSA of 3,000 plus. 18 of them didn't even have a biopsy done. It's based on the PSA, the rectal findings, the ultrasound, the scanning. And usually many of these are very old, they got a lot of comorbidities. So we make a clinical diagnosis of prostate cancer. But by and large, most of them have a biopsy. The next slide is about the treatment. So the treatment is, as Dr. Heng said, the mainstay treatment for prostate cancer is still anti-androgen therapy. Anti-androgen therapy, 47 of them, majority of them. The staging is done with biopsy, bone scan, and a CT scan. If it's early stage, then they go for the standard therapy. Well, I think probably the commonest therapy is robot-assisted radical prostatectomy. There are 22 of them. They used to have them done in Sarawak General Hospital. Then the machine expired. So some of them go to Kuala Lumpur, some of them go to Singapore. In my record, I have 2 patients who had an open radical prostatectomy done, one done by laparoscopic means. And for anti-androgen therapy, 2 of them had surgical orchidectomy. In other words, they have the testes removed by surgery, which used to be very commonly done. Only 4 patients, Dr. Heng, only 4 patients had the radical radiotherapy. Only 4 of them went to active surveillance. Although overseas studies, they are a bit different. Many of them are on active surveillance. Some patients refused all treatment. I couldn't locate 3 of my patients, and 1 patient passed away. So this is the sort of treatment demographic. So this is very traditional treatment, in addition to anti-androgen, we know that they are elderly people. They can have an increased risk of osteoporosis. So they all get supplements of calcium, vitamin D, exercise, sunlight. I haven't given them any bone agents. None of them receive upfront chemotherapy or any upfront, the newer drugs that we are talking about the last 2 years. When they get hormone castration-resistant prostate cancer, they get the newer agents, abiraterone, enzalutamide, apalutamide. And of course, the newest agent I put as XYZ. And some of the drugs are not even licensed to be used in Malaysia. 14 of them have a family history of breast or prostate cancer. And this is the group that we are going to talk more about tonight. So we are talking about a new era of, well, not actually new, like this has been around for some time, but now it's coming to prostate cancer as well, of looking for biological markers and in particular genetic markers for a better treatment. How do we confirm a diagnosis? Usually by histology, usually by transrectal ultrasound prostate biopsy. But we know the rectum is quite a dirty organ. So there's a risk of infection. So many places are moving over to transperineal biopsy, usually done under anesthetic, but sometimes under local anesthesia. So 2 of the group of the 28 have a transperineal. 1 of them presented to the orthopedic surgeon as a surgical spinal emergency, and the histology was from the spine. All of them are adenocarcinoma except for 1 of them, who is a neuroendocrine prostate cancer, and he presented with metastatic disease, and the PSA was only 40. So when you see somebody with a prostate cancer, PSA is not very high, think of neuroendocrine prostate cancer. So prostate cancer used to be reported as well-differentiated, moderately differentiated, and poorly differentiated. So when I first started, the pathologist was just reporting along those lines. Now we talk about a Gleason score, which looks at the cell architecture as well as the cell cytology. And not only that, they look at different areas of the prostate. They look at 2 areas. See what is the predominant Gleason score. So if it's 4+3 versus 3+4, they are different. So those which have a higher Gleason score are of poorer prognosis. So patients who are of say 3+3, then they are low risk cancer. So it's very strange, right? We have low risk cancer which may not need any active treatment. We can talk about that again another time, another day. Now in Malaysia, just now we mentioned that the prostate cancer actually is quite common among men, the 3rd. But if you put all the cancers together, it's number 7. But in terms of mortality, that means people dying from prostate cancer, according to a global can in 2020, is number 13. In other words, prostate cancer is very common. When we diagnose it, it's not so common. And to die from prostate cancer is even less common in terms of numbers. And in Malaysia, according to the National Cancer Registry, most of the cancers in Malaysia are diagnosed when they're in stage 4. Stage 4. Yeah, that means in advanced stage. So you may say, oh, this is Malaysia boleh, you know, everything is not so good. But actually, when you look at Asia, look at the developed countries in Asia, Korea, Singapore, Japan, Taiwan, these to me are considered as developed countries. And these patients presenting in their country also have a high incidence of non-localized disease at diagnosis. In other words, in Asia, prostate cancer at presentation is usually already advanced. So I have patients who follow up with me for other reasons, with a low PSA, and then certainly if in 1 or 2 years, the PSA jump up and become very high. So don't feel guilty if some of your patients suddenly get diagnosed with prostate cancer and you felt you have missed the boat. So somehow in Asia, prostate cancers are usually diagnosed very late. And we know since 1966 that the prostate cancer requires testosterone. So the treatment of choice would be to remove the surgical orchidectomy. It's the cheapest, it's permanent, but of course patients do not like to have the testicle removed, although I think it's still practiced nowadays, especially in East Malaysia. Okay, we know that once you induce menopause, there are so many side effects, cardiovascular, cognitive, metabolic syndrome, fractures, and things like that. So if you don't want to have a surgical orchidectomy, we move to a medical orchidectomy, medical castration. Medical castration involves injecting the patient with an agonist or an antagonist. So these injections are usually giving monthly, 3 monthly, or 6 monthly in East Malaysia. Some countries have a monthly injection. So this is called medical castration. So many of the patients that I've been telling you about, they're actually on treatment with my collaborators in the Gamma Hospital, among the surgeons, and also among the private doctors throughout Sarawak. So this has been a mainstay of treatment. But in the last 2 years, people are talking about better anti-androgens, sending them to the oncologist for chemotherapy. But unfortunately, in the 88 patients I've gone through, none of them are on chemotherapy. Okay, none of them chemotherapy. Only 3 of them are on the newer agents, simply because they are so expensive. The newer agents are so expensive, 10,000 per month. Of course, we can discuss whether money should be in the equation or not. The other important thing is that many of these patients, when they are diagnosed with cancer, they will search the internet. They will say, oh, there are special treatment, there are dietary adjustments, there are exercises and things like that. And quite often, they are at great expense. And of course, there may be some logic to this, because if you look at the Japanese in Japan, not the Japanese in US, they have the lowest mortality, okay? They have the same incidence, but they have the lowest mortality as compared to other countries, especially the American blacks. So it may be not only genetic, but it is also related to maybe the diet, in particular, the soybean diet in America. In the Japanese, I mean, absent in America. The Americans take a lot of animal fat, so they are a bit different. Okay, so what are the traditional prognostic factors? So in the past, we talk about the grade of the cancer volume, the lymph nodes, you know, the metastatic disease. But now we've got newer agents, which you will hear about in the next 2 lectures. And these 2 lectures, actually, which we're going to talk about, is also in the public domain. The public knows very, very early of any new findings, in particular genetic testing, although they're associated with this famous, beautiful actress, Angelina Jolie. She actually had her breast removed, both the breast removed, as well as later on the ovary removed, because she carried the gene, the mutation of the gene BRCA1, which actually give them a high incidence of these cancers and mortality from these cancers. Okay, so the public actually knows about it. So it's good for us to know something about this new thing that's developing in prostate cancer. I need to talk about this because we have been having many Zoom lectures on all kinds of new agents. And sometimes we try to use these drugs. So we have to be very clear in our mind the cost effectiveness of these drugs. If the cost effectiveness is only going to give you from 36 months to 31 months of survival, then whether it is worth the while or not. And also we must think of the quality of life. You take this new drug, what are the problems? Are they going to have a rash? Are they going to have fits? Are they going to feel very tired? are going to have heart failure, are going to have angina. So this is very important when we think about new drugs and cost effectiveness. So this is just an introductory slide. So obviously the treatment for many diseases, including prostate cancer, is evolving. There are many areas of discussion in terms of blood tests, in terms of imaging. Now, if you go to Australia, all the prostate cancer patients who have MRI, they will have a PSMA PET, not a PET, a PSMA PET, okay? And many of them will be going for genetic testing. So how is this going to fit into the overall care of patients in East Malaysia in terms of whether they're available, whether it's affordable, and how it affects the quality of life? So this last slide will help us to decide which are the patients that we can select for profiling, which are the patients we select for genetic testing, and which type of genetic testing, which disease to send for genetic testing. And in the end, if you give them a new agent, how it's going to affect their overall survival, how it's going to affect their cancer-free specific survival. So all these things are coming up, they are developing. Thank you for your attention. Dr. Hang?
Dr. Hang, you're muted.
You have questions
Sorry,
at the
can you hear me?
Yep.
Hello? Okay. So thank you, Dr. Clarence, for your lecture. Thank you for showing us your case series. It's very interesting. And thanks for giving us an overview of prostate cancer treatment landscape. So our next